You've probably been wondering why we've got these couches up here on the stage. I know Andrew has been wondering. The purpose of the next session is to actually share an opportunity for a discussion amongst a group of people, and I'd like to invite Professor David Currow, who is the CEO of the Cancer Institute and the Chief Cancer Officer for New South Wales, to join me with me now. And David is going to lead us through this next session. So thank you, David.
Thanks very much, Nigel. If the rest of the team would like to join me up here so we can actually use these couches. I didn't wear a skirt today because I knew we were going to be on stage sitting down, and it's most important not to. Before we start, I'd like to not only acknowledge the traditional custodians of the land, the Gadigal people of the Eora Nation, but I'd also like to acknowledge that this is a particularly tough week in the life of oncology in New South Wales. Rob Sutherland's funeral was on Wednesday, and Rob was a towering man in terms of research internationally, and led the Garvan successfully for many years, and was the inspiration behind the Kinghorn Centre. And this morning is Denise Lonergan's funeral. So it's been a very tough week for oncologists across New South Wales, and the panel has changed as a result of that. So the people noted in your programs are different to the people on stage, because we've had several people who have had to attend to other commitments today. I'd like to also reassure you, Rob's brother spoke at his funeral. Rob's sixth grade teacher at parent-teacher night said of Rob, look, he's okay in class, but I really think he's going to struggle to get a school certificate, and he's certainly not going to do anything after that. So, you know, if you have kids and you're worried about how they're performing, take great reassurance from that. Let me introduce the panel that we have here this morning. Professor Brian McCorn is known to many of you, a thoracic oncological surgeon, but also the chair of both the boards of the Agency for Clinical Innovation and the Clinical Excellence Commission. Professor Katie Clark, who is Professor of Palliative Care at University of Newcastle and has an appointment at Calvary Mater in Hunter, New England. Professor Stephen Clark, no relation, although you know, they do get confused from time to time and get each other's mail. Medical oncologist from Royal North Shore, with an appointment at the University of Sydney. Cathy Smith, who is the chair of Cancer Voices New South Wales. Great to have you here. Thank you, Cathy. And Lillian Daly, who works at the Cancer Institute and has a background in cancer nursing. So let's go, as Georgina did a little earlier in the morning, to a patient. A patient admitted 30 years ago, 1982, for initial chemotherapy for cancer at that time. Admitted to hospital, expected to be in for at least 5 days for the initial cycle of chemotherapy. That chemotherapy is going to be given every 3 weeks. That person is going to come into hospital for 5 days every 3 weeks, and is going to have a pretty tough time with particularly nausea and vomiting with this particular chemotherapy. It's going to be a real challenge to see through 6 cycles of chemotherapy. And overall survival, 5-year survival for all cancers 30 years ago, 48%. Let's fast forward to 2012. Stephen Clark, what are the chances of someone being admitted for chemotherapy today by comparison?
Very uncommon. We will admit some people if they're having cisplatin, which a lot of people had in 1982, although I wasn't working as a medico, I'm not as old as Brian.
He says that defensively, ladies and gentlemen.
He just looks a lot older.
So we would very uncommonly admit patients for chemotherapy these days. Our anti-nausea medications have improved out of sight in that time frame. In 1982, we had Maxilon was our only antiemetic. We used to have great huge vials of it that we had a little file that we had to open them with. We had wards full of people having what they used to call the black bag, and that made them incredibly sick. And it was horrible. I treated one young bloke, then ran into him in Franklin's in Northbridge one day, and he started vomiting because he associated me with feeling sick. And we don't...
Such insight.
And we don't experience those kind of events anymore.
Yeah, absolutely. Brian, you've seen changes over some of that period of time also.
Yes, I've seen some good changes and some bad. I think looking back, I am old enough actually to remember when I first went into this, and it is hard to believe, I know. Not only did we not have PET scanners and MR, when I first went into lung cancer management, we didn't have CT scans. And I can see some good old friend nurses out there nodding with me. When I was first there, all you had was a chest X-ray and this fuzzy image called a tomogram, which wasn't computed. So the biggest advance I've seen, so that people get the appropriate treatment, is the change in imaging, and I think we're just on the move with that again, with combined PET-CT. And we have to reflect that in our models of care, how we look after people. Someone who has an abnormality on chest X-ray should just have a PET-CT. All the other tests should be ruled non-refundable. It's absolutely a joke, all the tests that still get done. So there's a total... we don't drop things. We don't disinvest enough. And so the new PET-CTs are so accurate. The next round of PET-CTs or whatever comes next, we'll do it again. So imaging's the big change. And sometimes clinicians are very slow. I remember Professor Fulham and I tried to convince the haematologists to go to PET for lymphoma rather than all those nonsensical tests that were done and still done some places. And now they've adopted it so much that they want a weekly PET in true physicianly way of thinking. So there's a way ahead. That's one of the biggest things since you said 1982. I'm a little bit before 1982. So I'm talking starting back in 72. So that's the first thing. The second thing is multidisciplinary care. And that's not a meeting every week. That's a state of mind. And I get very upset when people say at multidisciplinary teams, you've got to log in who's there and sign it and document it. Multidisciplinary care is a state of mind, and you get that by working in multidisciplinary teams. I think that's not going to take great steps further forward, but I think it's essential if you don't have it, that, you know, people work in it. The third thing is personalised care in terms of chemo, and I'll leave that for Stephen to talk more about, but identifying that a cancer is not a cancer, not a cancer. It's a whole lot of different cancers. Things we thought of before that was just a lung cancer is not just lung cancer, it's that person's cancer. They're the big advances. What do I see as the big downer? And what I think I'm worried about will continue to get worse is that good old thing called compassion for the patient. I think there's a little bit too much science coming in and not enough compassion and caring. And that doesn't just apply to the clinical staff. How critical it is who sees them at the front door of the cancer centre. And I'm appalled at how I observe people being handled at front doors of hospitals when they're sick and worried. So what worries me most is I think we've lost some of that. And part of that, I think we've lost some of the ability to decide who shouldn't be treated. I think we're also full of ourselves in how good our treatment is and how low risk it is, that we are treating people who could be managed a whole lot better than in the traditional anti-cancer way. And I look to the consumer voices to bring that to the fore.
So, Kathy Smith, compassion, how are we doing?
Well, when I compare it now to when I was diagnosed and was treated for cancer, which is 16 years ago, it has improved, but there's a long, long way to go. I agree entirely. The science has crept into it in a big, big way, to the point of not only baffling the consumers and the patients, it can scare them. There's got to be a more open, friendly approach, and that's where I see the cancer care coordinators helping with that. This is a role they can fill very, very well. But the clinicians themselves need to approach the patients as people and talk to them on a level. The communication between the physicians and the patient needs to improve enormously. There's a minefield of misunderstanding there at times, and a lot needs to be done with communication.
And to take Brian's other point, have we got the message out there that people should be asking for multidisciplinary review of at the time of diagnosis of their cancer?
It's getting out there. We're working, excuse me, very hard to get the message out there. It is being picked up. I think CanRefer is going to help with that enormously. We now have to advertise the CanRefer, make people aware of that. And yes, the message is spreading.
Okay. Lillian, in terms of nursing and the care that we provide for people, how's that changed over the last couple of decades?
Well, I think the heart of nursing is the same, and I think it's all about compassion, and I think it's about absolute patient-centred care. But I think, I don't know why you're asking me about 30 years ago. I'm clearly much younger.
I actually said the last couple of decades for you. I gave you a major concession.
Fair enough there. But yeah, I think, care and compassion and patient-centeredness is at the heart of nursing. And I think the last time I cared for an oncology patient was 18 months ago, and it was still at the heart of what I did then. But I think there are increasing pressures. I think it's very difficult. There's a terrible workforce shortage, as you know, and that puts a lot of pressure on senior nurses and specialist nurses. So I think, that's one thing. I think, just thinking about what's changed in the last 30 years, I think it's Google, actually, is the one thing that's changed everything, because there's such an enormous amount of information out there, and patients actually come in with a lot of information and a lot of questions, and that's absolutely fantastic. But I think, the challenge now is to, I suppose, look at the information that's out there and sort of, what sort of quality information it is and how useful it is, to patients and clinicians. But I suppose the other thing I see is patients are much more empowered now and much more vocal and much more articulate about their needs, which I think is very, very good. And I think we need to take heed of that and somehow capture that and capture their experience and use that in the design of our services and care. And I think, patients are expecting more, and I think they should, and we should help them to expect more.
Could I just touch on that? I see less of it that the patients have Googled because they're frightened out of their life. They don't want to look what's on it. It's the daughters. It's the daughters. It's the daughters of the patients. The sons still have the packet of cigarettes in the top pocket like any good Australian bloke would. But the daughters have Googled and basically got a lot of it wrong, not their fault. But Google, as I say to them, I can put on Google that I'm the best surgeon in the world. I mean, in that case, it's a fact. But I mean, anyone can. So I mean, you've got to realise it's and you have to lead them through it. I agree with you that it's out there. If you handle it correctly, it's not a problem in management. I have to take one other exception though. Compassion might be still at the heart of nursing protocols. I'd like to see it a little bit more at the heart of nursing action. I'm sorry. Yes. But I think
Lillian, you're allowed right of reply about surgeons if you'd like. Stephen, Brian's talked about multidisciplinary care. I mean, is that making a difference to the clinical decisions that are put to patients on a day-to-day basis?
Yeah, it's really changed. It used to be sort of very... the surgeons used to run the show. They didn't think they needed other people. There's still some elements of that concept round. Not Brian, but there's still some element of that. But we have very good MDTs at North Shore. They're probably the best I've seen, and every patient gets discussed at the MDT. Sometimes it goes too fast, but at least it means everyone has been discussed. We look at the pathology. We have the radiologists are there to show us the X-rays and show us what the story is. We have a nuclear medicine physician showing us the imaging, and we really get input from a whole range of disciplines. We tell the patients it's like getting multiple second opinions, but they don't have to travel anywhere. So it works really well. And then the outcomes are recorded and sent round so that everyone approves them.
I think that's a really important point, and I know about some of the MDTs at North Shore, and I would agree that they're, exhibiting some of the best practice criteria for MDTs probably in the world. And one of the things I think that some of your MDTs do really, really well is communicate the plan to the GP. And I suppose my thinking is that moving forward, we need to get a little bit more creative about what we consider as a multidisciplinary team. And all the care and all the decisions can't be made in the tertiary hospital. We've got to think about, other people that we really need to start including in a real way as a multidisciplinary team for cancer patients.
And early on the palliative care physicians as well in many cases.
I'm just about to get to palliative and supportive care. Katie, Stephen mentioned very early on antiemetics. How has supportive care and that transition to palliative care changed
I think Australia is probably one of the most exciting places to be a palliative care physician, and I think it's largely due to the chair of this session. The evidence base from which we practice now has increased significantly. Things that we used to do, I do things because my senior colleagues used to do them. I've had experience, I've seen they've worked. That's no longer acceptable in palliative care, and Australia has really led the way in making sure that we practice from an excellent evidence base, and I think people in palliative care should expect that from their palliative care clinicians. What I am saddened about, though, I don't believe palliative care integrated into multidisciplinary teams has actually moved that further along. I think the majority of society continues to believe that palliative care for cancer patients is an option when we can no longer do anything. And I find that very distressing, the notion that people will be told we can't do anything, we'll refer to palliative care. I think palliative care has a very active role to play very early on in people's illness. One of the best multidisciplinary teams I ever worked in was the gynae-oncology team at Royal Prince Alfred. And at that point, if a patient had a particular distressing problem, for example, ovarian cancer, oftentimes one of the first presenting symptoms is pain. And I used to see people at the time of diagnosis, and my role was very much to help settle down a problem and allow a person to move forward with their treatment better. Now, I may not have seen that woman again until much later again in her illness, but palliative care was seen as integral to the management of that team. The one problem I also have, and I have to mention this, David, although multidisciplinary teams are a fantastic option for people who live in Sydney, I would also question the access of a lot of our rural and remote residents of New South Wales, whether or not they have the same access to such optimal multidisciplinary team approaches to management. And I would suggest that having worked now outside of Sydney, my eyes have been very open to the fact that that's not a universal expectation of all residents of New South Wales, that they'll have the same level of multidisciplinary team that they'll receive, team interactions that they'll receive in Sydney. And I think that's a big problem. And I think we, as a society of health professionals, need to consider how we can make sure that regardless of geographical location, people have the same access to care. Because people are refusing care because they actually don't want to come to Sydney. They want to stay in their own environments, and I can understand that. Thank you.
So how do we get that balance right across the panel? I mean, that issue of access versus centres where, particularly for rarer cancers, you are concentrating the efforts, the technology, the skills in order to get better outcomes. How do we get that balance?
Telehealth. I mean, we already do. Our Coffs Harbour joins us every second week at the Prince Alfred one. I join the Port Macquarie one only by telephone at the moment, every second week. We saw some great stuff last week up in the Hunter with the Minister at the Minister Advisory Committee on different aspects of telehealth and the advances that can be made. Our own Governor of New South Wales used telehealth many years ago when there were no psychiatric services down in the Murrumbidgee when she was in charge of adolescent mental health in central Sydney. And the advances are just going. A wonderful thing we saw last week was the palliative care of a 2-year-old child with a muscle dystrophy who was going to die and was in Sydney at a teaching hospital, then went to Newcastle, and then went home to a town out the back, to a village out the back of nowhere that was handled brilliantly by an iPad. I mean, there's just so many ways we can do it. I agree very much with your comments about everyone having access. There's no reason they can't. Like, there's no reason now that any hospital should not have access to radiology services because of PACS RIDS. A great development we did through IT starting 5 years ago, now just about rolled right out as planned. All of those things make it possible. The thing we mustn't lose in all this, though, and the only problem I sometimes have with multidisciplinary care is someone has to own the patient. Sometimes they get lost, whether it's multidisciplinary care for cancer, cardiac. A patient rang me yesterday who I'd coordinate a whole lot of things, and he said, I've seen 6 cardiologists and 4 cardiac surgeons, but I don't know where I'm going. And I became the broker, and I see a great future in retirement for being a broker of care. In New York, you'd have it. And in fact, you've got to have someone, and the multidisciplinary system I work in at Prince Alfred, someone is identified as taking the decision back to the patient and their family. Because in my field, you don't actually have to see the patient in the actual multidisciplinary thing. It is an imaging thing. So someone has to own them. And we mustn't lose that. And that's what I'm talking about, the compassionate nature of our care, relating to them, getting the answer back to them that day, getting the result of the scan back to them that day. All of you must have family members, all of you who've had cancer, and how tense it is waiting for that result. And in almost all the tests that the physicians have ordered, physicians, meaning doctors generally, in almost all of them, there is no reason the result can't be back that day, and a phone call to them. And the relief on their voices when you ring them, the first thing they say is, "I can't believe you're wrong." Let's up our game. That's one of the things we must do, and that's what I'm talking about, compassion rather than science.
Kathy, you were nodding?
Yes, I agree with that entirely, but it's not only with the MDTs that needs to happen. We need ownership at the end of, coming towards the end of life too. That is a big vacuum at the moment where patients are passed around from pillar to post. They could go from palliative care or rehab to palliative care, back to acute care to home. No one is taking ownership. No one is taking responsibility for that patient. And the family, the carers of these patients are just left floundering. They don't know where they're going to be going next. They don't know who to speak to, what best to do for their loved one. There's no one taking any responsibility whatsoever, and that is a big problem that needs solving.
So in 30 years, have we engaged better with general practice or not as well? I mean, in terms of a central person, the general practitioner in the system is supposed to have some key roles there. Stephen?
I think it varies greatly depending on the general practitioner. We tend to take over a lot because we're not sure about the quality of the general practitioner or whether they're going to a medical centre, whether it'll be a different person each time. So a lot of our models rely on good contact with community nurses or with the palliative care team or with our own nursing staff who can contact the patient and keep an eye on them. If there's a GP who's good and interested, involved as well, who can go and see the patient, we regard that as a bonus. But we tend to cater for the worst scenario most times.
Is that sustainable?
Possibly.
Okay.
Possibly. Communication's our big problem. Getting access to information. Brian's model would be ideal, but I spend half my day trying to get results because I've been protected by 3 different passwords, or the privacy laws won't let me look at the results ordered by somebody else. And if this was facilitated by results available on websites that I could access without 3 passwords, it would make, or use an iPad or an iPhone or something else. This would really make communication a lot better. The technology, I don't think we have really sorted out yet.
So the iPads are the go, as I keep saying. Where I trained at the Mayo Clinic, every resident, every registrar, every fellow at the Mayo Clinic is issued an iPad. They walk around with their iPad to get information immediately available. You all know the frustrations with your iPads in New South Wales Health, and the minister's aware of this and been put it out at meetings with our information. All of this information just should be so easily available. I mean, it is a nonsense to hide behind things that we can't get that information. In terms of general practitioners, we intend exploring all this through Medicare locals. If the Medicare local model works as opposed to the previous division model where it worked in some elements, there are different, not just GPs, but there are different environments where there are groups which have already been working along a Medicare local option. We have to look at increasing it across the whole state. But you've got to decide, when you're the doctor looking after the patient, who will make it happen. And to be quite honest, it's sometimes harder for the patient to get an appointment to see their GP than to see me.
Absolutely.
I mean, it's amazing. The number of patients that tell me that, because we always had, my practice, I run a 6-man practice, and our rule is you can see someone today or tomorrow. If you want to see someone specific, one of the 6, you may have to wait that week until their day. And we have to offer that to cancer patients. I'm a little weary of being told by other cancer specialists they can't fit in a new patient when the patient has cancer.
Or even worse, when they're using it as a political weapon to try and get increased resources, and they create artificial waiting lists for their patients. That's just crook, I reckon.
So we've highlighted some of the great things that have happened in the last 30 years. Have any of the innovations not delivered what we had hoped in terms of improvements?
Immunotherapy.
Yeah,
I mean, we've had things come and go.
There are still some drugs out there looking for a disease, aren't there? Great therapies, they just don't know what to treat yet.
Fortunately, the immunotherapists could go into allergies, so they had a career at least. But I mean,
what about robotic surgery, Brian? Delivering better outcomes?
Probably overall. Probably not. If you look at cancer survival, you've got to look at the things that make the quantum leaps. Little boys have little toys and big boys have big toys. And robotic lobectomy is done in some centres overseas mainly at the moment. Thoracoscopic lobectomy is done. The gains are small, but there's no doubt the technology will develop and get better, a bit like what's happening with robotic prostatic surgery.
I was about to say prostate rather than lung. What do you think?
If you talk to the prostate surgeons that do it, in terms of current techniques, you've always got to be careful comparing a new technique to the way they used to do the open operation. And it was interesting having a conversation last week with a urologist about the prostate surgery. It would appear that continence is better after the surgery. It's interesting, and you've got to go back to the patient. There is out-of-pocket costs at this current time to have a robotic prostatectomy. Minimum $5,000. Now, we're not all Kerry Packers, right? And I'm being serious. It's not like America, when I was there, people would mortgage their house if that's what it costs to take what they saw as best technology. So this fellow who works mainly in the South-Southwest, he puts it to the patients that I can do this prostate with the robot. There's slightly better continence rates. That's the main difference. And they say, well, what does that mean? He said, well, unfortunately, it does mean, not for him, $5,000 out of pocket for the hospital. And they say, well, what else is the option? And this is what we see in some of the data from the chart book at CEC, how people make decisions on things. And when he tells them about it, the open, a few extra days in hospital, a bit longer, they say, I can't afford the $5,000. And that's a matter of fact.
Yep. Stephen, in terms of targeted therapies, are they all delivering better care? The bill's gone up.
I think they're chipping away at it more than anything else at the moment. And I think we're getting good ideas as to how tumour biology is working and which patients might benefit from certain treatments. But cancers get very clever, and it's real evidence of evolution that the cancers evolve in response to the treatment, and we select out resistant populations of cells that the drugs don't work against. But we really have improved in a whole range of diseases. When I was a registrar, we didn't treat patients with metastatic melanoma, renal cell cancer, colon cancer, a whole range of different cancers, and there have been major improvements in that. Colon cancer, I was given when I came back as a consultant to Westmead because there weren't any treatments, and I was the new boy. I got the disease without any treatments, but that's the best thing that ever happened to me. In that time frame, there's been more new treatments introduced in colorectal cancer, and we've changed the nature of treatment of both advanced disease but also in the adjuvant setting so that we're actually curing a whole lot more people with that disease.
Can I just say, Dave, there's a very interesting paper was published in the New England Journal a while ago, and it looked at, survival was not the primary outcome, but serendipitously it was noticed in this paper that a referral to palliative care, and palliative care wasn't actually defined in this paper, what it actually was, but serendipitously in this trial it was noted that people who were referred in the referral to palliative care arm actually had improved survival rates. And I would suggest if palliative care was an immunotherapy, we might be doing a lot better in terms of referrals.
There are certainly antibodies to palliative care, so the immunotherapy may well work.
Can I just say one thing about palliative care, that the ACI, with the Minister's support, had its first forum recently to establish the palliative care network, and we recognise all the things that have been said. And that's why it was established. It's been funded. It's one of 2 new networks in the ACI, just wearing my other hat, David, and Nigel's over there. I mean, rehabilitation's another one, and palliative care. And it was very well attended. There's work to do, and funding's an issue. And I noticed some of the questions coming from the group relate to funding of things like palliative care against acute care. And there are constraints. and there are requirements, but people have to decide some of that stuff about at the end of life. That's a big thing that's in cancer care we haven't touched on yet. And I would hope to see that we get over this hang-up that everyone in our hospitals has to die in an intensive care unit. That's one thing I have great problems with, that, and that advanced care directives is something I would hope in the short term we might move along some reasonable discussion. Politicians have trouble with it without us, right? The politicians can't lead it, I don't believe, but I believe that is one of the next things that has to happen. We've done all this fancy technology and stuff. Robotics are irrelevant, and I'm being serious, compared to end-of-life planning and decisions.
Lillian?
Yeah, can I just say so? I have actually been around a long time. I'm older than I look. But
That's my life.
So a very long time ago, 25 years ago, we had a problem integrating palliative care into haematology because it was just regarded as an absolute, you didn't talk about palliative care. And it seems that it's still the same problem today. So I know it's quite left field, but maybe we need to change the name and call it supportive care or something that's a little bit more palatable. It seems to be an ongoing problem. So that's just,
I think that's part of the problem. I think the healthcare people haven't worked out in their mind what palliative care is, and they need to be mentioning that to the patient the first time they meet them, and say that it's possible that your treatment might work for a while, but in the end you might need to have some palliative care, which is symptom control.
But I just wanted to also say something on what Brian had talked about there in terms of the robotic surgery, and I know that there's a lot of difficulties with evidence in the field of oncology, but I think we need to move more towards some sort of robust decision-making framework that actually includes the patient as an informed participant in the decision-making process. And I would see that as something that I hope we can work on in the next 10 years.
So does that mean the patient should be at the multidisciplinary team? No. Kathy?
Certainly, if the patient wants to be.
Yeah.
Most definitely.
I think it would be impossible in the models that are running at the moment. Our multidisciplinary teams, we run 3 in a row, and it takes us from 3:30 till 7 o'clock to get through them. And if we had the patients and their relis there, we'd be there all night.
Might be some good. But, it depends what sort of multidisciplinary thing it is and whether you need to examine it. Like one of the early multidisciplinary care was head and neck cancer. Mm-hmm. Patients was always there because the decision as to determine what treatment, and would it be examined by the great late Chris O'Brien, by the radiation oncologist, by the chemotherapist. They'd all examine the patient because it was critical to what you were going to do. In other specialties like mine, the critical issue is the radiology, and a bit like Stephen, but I have no problems if anyone wished to be there. It's not, most of us haven't set them up like that because it's not the critical step.
And does it change the conversation between, you want a couple of pathologists actually battling out to decide on a diagnosis at times. Is it going to change the conversation if the patient is there and that conversation is dampened?
I
think that would just be an initial event. Mm-hmm. It's hard to dampen some of us from
if a patient, if I can just, with the multidisciplinary teams, treatment is discussed. What about quality of life? And would the discussion on quality of life, if the patient was there, be more in depth? Instead of just the treatment, are the side effects of the treatment going to be?
But Kathy, do you think it's about somehow getting the patient's preferences to be considered at a multidisciplinary team, or in the sense of a multidisciplinary care? Could we move towards? Well, I'm just thinking about the sorts of information that are taken into account in making decisions at multidisciplinary team level. Do you think that in terms of what the patient's preferences for treatment, their social context, lots of other important information that's going to determine whether or not the patient decides to follow through with the treatment or is capable of following through with the treatment? Are there some better ways of getting that sort of information included, or perhaps it's already included?
It depends entirely on the patient, I think. I don't think we can... one of our members who... she insisted on being at her own multidisciplinary team meeting, and she got a lot of benefit from it. Now, personally, I would hate it. I wouldn't want to be there. So you've got the two extremes, and you've got everything in the middle.
It's not a one-size-fits-all.
No, not at all. Not at all.
So 1982, 48% 5-year survival. 2012, that's now 66%, according to the Australian Institute of Health and Welfare just a few weeks ago. A massive change. And if we actually project that change out, by about 2037, we will see some cancers approaching zero. Some cancers. Let's look to the next 20 years. What's the thing that's going to make the most difference to continuing to improve cancer outcomes? I mean, the message is not out there in the community that 2 out of 3 people diagnosed with cancer will now be alive in 5 years' time. We've got a huge communication challenge, but at a systems level challenge, because pretty much everything we've spoken about this morning is not at the individual level, it's at the systems level. What's going to make the biggest difference? Let's start at this end. Lillian?
Thank you. I think it's about data and information, actually. I think it's about, finding better ways to systematically collect data, all sorts of data, and have an integrated system. And, looking at all of the information that we need, including patient-level data that we're actually, reporting up from patients themselves, and using that and converting it sensibly into information that we can feed back at every level of the system to drive change. And I think having patient-level information and patient experience of care and treatment is an essential and sometimes missed element of data or information that's included perhaps in decision-making at all levels of the health system.
Okay, so patient-reported outcomes, patient-reported experience.
Yes.
Kathy?
Personalised care, big developments with personalised care, specialised centres, and also one thing that we would like to very much see is GP training, if you like. We all know that the earlier of diagnosis, the more chance of a successful outcome. Recognition of symptoms by the GPs, by the doctors. What can we do to educate the doctors to recognise the symptoms of cancer, of all the various cancers? That we see is very, very important.
Okay, thank you. Stephen?
I'd go education and research in addition to the data, but in particularly educate the doctors across the board as the optimal treatments, but also educate the patients about lifestyle things that might lead to cancer, get them an early point that obesity may not necessarily be a good thing for you, lack of exercise may not be good, understand that cancer's a nasty thing, if you get it you might die from it, really educate them about changes in lifestyle, as I think that's probably going to be the biggest increment in cancer over the next few years. I think continuing to fund research locally. 20 years ago, everyone basically had to go overseas if they wanted to do cancer research. Since the Cancer Institute's come along, people have been able to stay in Australia, do research, and that's given us more research on site, but also more people in the workforce who can contribute. So I think continuation of those will improve outcomes the most.
Great, thanks. Katie?
I think acknowledgement that as our society lives longer with chronic illnesses, and cancer is, that the prediction you make, David, is that cancer will essentially become a chronic illness. Living with a chronic illness for many people is a place that's where people are burdened by symptoms. I think as a society we need to consider how we can upskill health to provide a compassionate and palliative approach to all people who need it, regardless of where they are in their illness trajectory. I think we need very clearly defined referral pathways to this group called specialist palliative care, so that we can help address the physical and psychological symptoms that people with chronic illnesses or people who are imminently dying of cancer live with, so that regardless of how long you've got to live, you live as well as possible, supported by a system that acknowledges that you are living with problems.
Great. Brian?
Well, I'm disappointed, David, that you set the 5-year time period.
No, I said 25 years.
No, living 5 years.
Oh, right.
My wife has cancer. She doesn't think 5 years is a very nice period. I don't think 5 years is meaningful. I think we've got to get over the paradigm. There's 2 great questions down from the panel. Will the panel subscribe to the motions? Patients don't care how much you know until they see how much you care, which I totally agree with. And secondly, do you see a role for nurse practitioners to be the interface between GP and specialist follow-up? That's the only reason I've been successful. For 18 years, despite every director of nursing trying to roll her, I have had a care manager for thoracic oncology patients, thoracic cancer, surgical oncology patients. So, great questions. I think we've got to ask, everyone goes on about this 5 years. As you mentioned, cancer is essentially a disease of older age. Some patients, 5 years will not be relevant. It's how you live with the cancer. Mm-hmm. So let's get over that fixity that 5 years means something. I don't think it does. And I think I take great offence at doctors telling patients the percentage chance of them living 5 years. They won't live yes or no. They will live yes or no 5 years. They won't have a 20%, 30% or 50%. So I'm a bit over stats. I'm a bit after how we look after the patients. And I constantly am amazed by people who appear to have disease. Everyone would say they'll be dead in 5 years because that's what the books, the latest journal, The Lancet says, who keep living with their disease. And I think that's where we've got to go. And, you know, in that we'll cure the ones that are cured. Fine. But let's look after all of them. And when we look at specialised centralisation, as I think we should in, for example, esophageal and pancreatic resections for cancer, we shouldn't just be looking at that small component of it. We've got to look at how those people with those diseases are looked at totally. And I'm totally with the palliative care thought from the start, because that's what we have to assess in many of our patients, even those we cure, right? It's a lifelong thing, this. So I want to see a real swing. I'm not anti-science, but we've got to use the science in a compassionate way.
The other apology for this morning's panel was, in fact, rehabilitation in cancer. And I think we have to focus strongly on making sure that people can move on with their life as well as possible. And that's not just great symptom control, it's also recovering from some of the things that we do in treating cancers. And we really only put red flags up a long way down the path. And we can do far better in that space than ever before.
I just have to say I've had an urgent page, I'm sorry. It's from a member of the audience. Professor Cregan has sent a request for more robots. So I'll be shot if I don't mention it.
We'd hate to see you shot, Brian, under any circumstances. Ladies and gentlemen, Brian has drawn attention to the fact that having birthdays is the biggest single risk factor for cancer. And if we learn nothing else from this week, all of us need to smell more roses and eat more ice cream. Ultimately, we have to ensure, however, that at a systems level, we are continuing to improve the care that is delivered to people, hand in hand with the science that is being developed. The opportunities for the next 2 decades are, in fact, incredibly bright as we think about cancer. And as we think about innovation at a systems level, as well as the individual care that is delivered to 40,000 people who this year in New South Wales will hear the words, "You have cancer." Let's make sure that as we take a health system forward, that we are responding compassionately and with care to the needs of people right across our community, wherever they live, be it in metropolitan Sydney or in the most rural and remote areas, to ensure that their outcomes are the best possible outcomes that can be achieved anywhere in the world. Will you please join me in thanking the panel this morning for a great discussion.
I just wonder if we might have a time for a couple of questions from the audience. I know that there's been interactions and you've woven in some of your responses to the feedback you've been receiving from the audience through the text messages. But have we got any final questions, 1 or 2 questions from the audience before we wrap up for this morning's session?
Mohammed Kadra from the Nepean Hospital, which is very grateful to the Minister for the robot. And we do offer it for free, Brian. All public patients can have their robot there for free. But the nature of my question is really more about end-of-life issues. I think as a urologist and certainly working with oncologists and MDTs, often we see patients where the cause of suffering because of artificial prolongation of life through clinical trials, through chemo, through false hope. And I just wonder how we're going to start this conversation in New South Wales. Often the problem happens at the admission and casualty way before I'm involved and way before any of the panel members are involved. And I just think that maybe, and this is consideration for the Minister perhaps, we need a day like a symposium such as this, just to talk about dying in New South Wales as opposed to some of the innovations.
Can I talk to that? We actually undertook a randomised trial of that at Concord, Mohammed, and what we did was have the patients were randomised to either our standard care, which was a leaflet talking about end of life. And the other randomisation arm was to spend time with a clinical psychologist and to go through the issues. And as well as people feeling better about the whole process, we actually reduced the number of people dying in hospital, the number of Met calls, and a whole lot of different end-of-life parameters. So I think you're right, we need to spend more time in this. The patients weren't more distressed in the arm where they were discussing all these issues rather than the arm where we just gave them a pamphlet. And I think it's an approach we have to take further. The paper's under review in Journal of Clinical Oncology, and we hope it'll come out shortly, but it was a really useful study for us.
And the other thing I'd add in there, Mohammed, is there's no doubt that there are units around the state that have a strong interface with the emergency department between the palliative care providers and emergency, and other places where that relationship is totally non-existent, and we can have a much more consistent approach in order to ensure that interface is a strong one, because you're quite right. Once that opportunity is lost, so many other opportunities will have passed by.
Steve Flecknoe-Brown, and I think after 13 years in Broken Hill I can bring a bit of a rural perspective to this. Thank you, all the panel, for what you've said. I won't go on too much on the preamble, but the compassion issue keeps coming through, and also the workforce misallocation or misfit is a continuing theme in rural and remote Australia. As far as I'm aware, there's only one medical oncology group outside of a metropolitan area, and that's Albury-Wodonga, hardly rural, and one other medical oncologist living and working in rural Australia. So we will not get medical oncologists out there in rural and remote Australia. We will have to depend on video conferencing. Please, I've seen them happen. Please teach these people how to use the media. Right? You can actually have a very good interaction over over a video link if you know how to use the medium. But if you don't know how to use the medium, the patient comes away feeling really let down and really no connection at all with the person who they see as being very important in their care. The other thing is that what we do have, what has been very successful, and please, Minister, we want more and more of them, is the rural cancer coordinators. These are locally based people, usually highly experienced nurses, known throughout the community. They are like sheepdogs. They get round and they make sure everything happens. So those are the two solutions that are going to help us in rural and regional Australia.
Only a chair of a board can suggest they're like sheepdogs, Steve. But I would just hasten to add, however, that we've now got resident medical oncologists spread right across regional New South Wales. Not only Albury-Wodonga, but in Wagga, in Tamworth, in Coffs Harbour, in Port Macquarie, in Lismore. I mean, the picture really has changed dramatically in the last 5 years, and I think that's one of the reasons that we are genuinely seeing differences in survival, and we're going to see that discrepancy between New South Wales and the other jurisdictions in Australia grow because of the investments that are being made in ensuring that regional care is there and is sustainable.
And about to be Orange and Bathurst, and there are also radiation units in a number of rural centres.
Port Macquarie, Tamworth.
Well, one final question before we break.
Yeah, thanks. So over the years there have been innovations in bureaucracy, and I don't say that in any sort of positive sense at all. And until recently I worked in a hospital as a researcher, and the amount of bureaucracy that stifled us doing even the most basic things was quite alarming. I hate to think what this is doing for healthcare services and for the patients. And I'm making the distinction here between bureaucracy and useful administration. I think it would be nice to see the probably billions of dollars that are wasted in bureaucracy put into frontline services and patient care. I'm just wondering what the panel thinks about that.
I think the Minister would probably like to respond to that. True. I think that's one of your key things, isn't it, Minister? I think Minister should be asked.
Okay. Minister. Nothing like the chair putting the Minister on the spot.
Thank you. I actually left that part out of a prepared speech because I thought most people in this room had heard the message about what we've done in devolving the management and administration of health. We've actually reduced the size of the Department of Health by 25%, created instead a Ministry of Health, which is very focused on this kind of thing, strategic policy, purchasing services from the districts. We've shifted that middle layer of the bureaucracy down to the districts to give the districts, which are really much more now accountable for the services that they provide, to give those districts the skills that are needed in good management. You know, the financial management, the management in terms of developing e-health and so forth. So it's very much what's been on our agenda, and if anyone in this room can think of any bad bureaucrats, I'd like them to go to their board and tell them, because the board now has a responsibility to ensure that resources are used in the best possible way, and if there is wastage of money, who are doing administrative or bureaucratic jobs that could be better converted into better patient care, new models of care, support for frontline, then that's what I'd like to know, and certainly the chairs of the boards would like to know. Thank you.
Thanks. Thanks, Minister. So we've given the Minister the final word for the morning. Can I thank everyone for their contribution? Can I thank the panel for the last session again?